WPSU is your source for Penn State sports, Penn State research, Penn State community. But we can't do it without your support. Become a member today and get a DVD of your favorite Penn State show.
From Penn State University, this is Pennsylvania Inside Out, connecting communities to a world of creativity and knowledge. Here's tonight's host, Patty Satalia.
Tonight on Pennsylvania Inside Out, if you or someone you love has been diagnosed with breast cancer, you are probably confused, afraid, perhaps even angry. But you are not alone. More than 2 million women in the United States today are breast cancer survivors. Where are we in the fight against breast cancer, and what more needs to be done? We'll talk about that with a renowned surgical oncologist. Dr. Monica Morrow is Chief of Breast Surgery Service with the Memorial Sloan Kettering Cancer Center located in New York City. Thank you so much for joining us.
Thank you.
Where are we in the fight against breast cancer? And I'm wondering what are among the most significant advances that you've seen in the last decade?
Well, I think we've made remarkable progress against breast cancer, which people sometimes don't realize because we haven't solved the problem completely. But first and most importantly, the death rate from breast cancer has gone down in the last 5 or so years. That's half because of the increased uptake of screening mammography in America and half because of improvements in treatment. I think what we've started to do, which is our really long-term goal, is be able to individualize treatment. So 20 years ago, all women were treated with complete breast removal, a mastectomy. Today, we have options of mastectomy, of breast-conserving therapy, meaning lumpectomy and radiation, or mastectomy with immediate breast reconstruction, and we have lots of ways to do it. We've decreased the side effects of therapy. It used to be that there was no choice but to remove all of the lymph nodes under a woman's armpit to see if cancer was there. Now we have what's called the sentinel node biopsy, where we can take out just 1 or 2 lymph nodes, which will accurately predict whether or not there's any cancer in the remaining nodes, sparing women's side effects. I think the other thing that is just beginning to come into clinical practice is that we have entered the era of genetic medicine. We can look at the genes in an individual woman's tumor and start to use those to predict, number one, prognosis much more accurately, so we can spare women with a good prognosis unnecessary treatment like chemotherapy, for example, and identify those women who are at high risk and need very aggressive therapy. So it's a very exciting time, and progress has been made.
You are a champion of setting standards, not just nationally, but internationally. And I'm wondering, for the average American, regardless of where she lives, how good are her options when it comes to treating breast cancer?
Well, I think there's no doubt that where you live still influences your treatment. For reasons we don't entirely understand, we continue to see geographic variations even after you control for things like education, income, the stage of the cancer, that if you live on the East Coast, for example, you're much more likely to get treated with lumpectomy than radiation than if you live in the South or the central part of the country. And we're trying to understand why. One of my personal areas of research is how women make decisions relative to breast cancer treatment. And it turns out that some things we've thought were physician-driven, that is, physicians were not accepting new research. Turns out it's not the physicians, it's the patients who somehow believe that more radical surgery offers a better chance for cure.
People often look at a cancer diagnosis as kind of a ticking time bomb, and that is not always the case. Some of the cancers out there are slow growing. Give us some advice in terms of how to use make the best use of our time, energy, and our resources.
I think that's a very important point. I mean, obviously, your first reaction when you get a diagnosis of a potentially life-threatening disease like breast cancer is to say, I want everything cut off tomorrow, preferably, if not today. And it's important to recognize that from the time cancer starts as a single cell in your body until it gets to be the smallest thing we can find on a mammogram, it's been there a year or two. We don't have any tests that could find it, but it's been there. So the idea that if you don't get treated in a day or a week, somehow you're going to increase your chance of dying of breast cancer just doesn't make sense. So my advice would be take the time you need to gather the information to make a good treatment choice. If you're not hearing anything your physician is telling you because you're still so panicked about the diagnosis, take a deep breath, wait a while, talk to friends, counselors, whoever will help you, and then get another opinion so you have a better chance of hearing all of your options.
But I've read that on average, a woman might talk with her cancer doctor for 1.3 minutes.
Well, that is an interesting statistic. I mean,
in terms of asking questions, I should.
I think that, you know, preparation is a good thing. Come with some questions, but make sure you want to know the answers. Sometimes people come with a book and they start reading you the questions, and I say, well, why do you want to know that? It actually has nothing to do with your situation. They say, well, it says here you should ask it. Those aren't the kind of questions you want to be asking. Get a family member to come with you and help you. Tape your conversation with the doctor so you can go back and listen to it at your leisure. And if you're going to use other sources of information in today's internet age, make sure you're using a reputable source. The American Cancer Society, the National Cancer Institute, the Susan G. Komen Foundation, all of those have medically appropriate information.
So how do you find a good doctor, the right doctor for you?
Well, I think, number one, there is no right doctor for everyone. That's an important point. I think that, in general, doctors who treat high volumes of breast cancer, we know have somewhat different practice patterns than those who don't. That is, they are more likely to endorse breast-conserving surgery. You are more likely to get access to a clinical trial. And some of our research shows better patient satisfaction with communication styles. Going to a hospital that is either a cancer center, a National Cancer Institute designated cancer center, or participates in national research studies is another way to assure that you'll get state-of-the-art clinical trial information. And then talk to people, your primary care doctor, your gynecologist, your neighbors, about doctors they know that they may have had a good interaction with.
Speaking of clinical trials, there is at least one clinical trial for almost every cancer out there. How does one decide whether they ought to participate in one or not?
Well, one of the biggest obstacles to progress in cancer research in this country is that only about 8% of cancer patients participate in clinical trials, which are really the only way we can tell if a new therapy is better than a standard therapy. So what I would say is you have very little to lose by participating in a trial. These are studies that have gone through incredibly thorough review for safety because they cost millions of dollars to do. They're testing a treatment that has already been shown to be very promising, and they compare it to the standard of care. So at the very worst, you're going to get the best standard of care that we know. And research, interestingly, shows that patients who participate in clinical trials tend to do better regardless of which treatment arm they're in, just because they're so carefully monitored.
But clinical trials have gotten a bit of a black eye in recent months, especially among pharmacological trials, because the bad news sometimes isn't reported.
Well, yes, and I think it's important to distinguish. All clinical trials are not created equal. There are some trials that are sponsored by the pharmaceutical industry, some of which are very good, but they are controlled in some ways by the pharmaceutical industry, including the publication of results. Then there are trials that are funded by the federal government or by research agencies where there is no pharmaceutical oversight of the results. They're published for the scientific community. So I would say those are first-level trials. Pharmaceutical trials give you access to new drugs, but there are some issues with them as they exist.
Now, one of your research focuses is getting the results of these clinical trials into daily practice. How difficult is that to do? What are some of the obstacles to getting things on basically into onto the factory floor?
Well, I think that's an important point. There's good news and bad news about breast cancer. The good news is that it's changed dramatically in the last 30 years. The bad news is it's sometimes hard to keep up with what is really standard proven new therapy, what's experimental but is being hyped to the public, perhaps prematurely, and it's hard not only for patients but for doctors to keep up with that.
What progress have we made in the fight against breast cancer, and what more needs to be done? We're talking about that with Dr. Monica Morrow, who has been credited with making a huge contribution worldwide to developing standards of care for women with breast cancer. She's chief of breast surgery service with the Memorial Sloan Kettering Cancer Center in New York. This year, in 2008, more than 40,000 women will die from breast cancer in the United States. But on the flip side, there are 2.5 million breast cancer survivors out there. And I'm wondering, based on your experience, what factors influence who will live and who will die from breast cancer?
Well, there's no doubt that the biology of the cancer that you get, which is something that you can't control, is a major determinant of whether you will live or die. So, for example, there are some women who do everything they should do. They get their annual screening mammogram. Their cancer is found at the size of a head of a pin, but it's just a bad cancer, and there's not a treatment that will stop it. On the other hand, we do know that getting a mammogram once a year after the age of 40 reduces your risk of dying of breast cancer. It's the only test that's been shown to do that. If you are a woman at high risk for breast cancer, you have a major family history, particularly of younger women in your family with breast cancer, you have certain uncommon benign breast diseases, you have a mixture of reproductive factors like having no children, having your children after the age of 30, all things that combine to increase breast cancer risk. We now know that the drug tamoxifen reduces breast cancer risk by about 50% in high-risk women. That's an option for prevention that wasn't there 10 years ago. Treatment has also improved. And we see an unfortunate number of women who have read things, for example, I don't want to take tamoxifen because it causes me to gain weight. Well, first of all, tamoxifen reduces your risk of dying of breast cancer by a good 40%. But second of all, it doesn't cause you to gain weight. That is an internet myth. So I think that standard treatment is standard for a reason. It's met scientific standards.
You mentioned earlier that breast cancer death rates are declining, and there was a federal report in 2006 which indicated that it stopped increasing in about 2001 and started to decrease in 2003, but they didn't seem to know yet whether this was an anomaly or a trend that we could expect to continue.
It looks like this is a continuing trend. Death rates are continuing to go down. Most notably in white women, but also in African American women and in other ethnic groups, although the statistics for those are not quite as mature. And it looks like about 50% of the decline in death rate is due to the fact that more and more American women are getting screening mammograms, or up until very recently have been, and that treatment has improved, and that accounts for the other 50%.
Now, you said we're getting screening mammograms up until recently. There has been a lot of talk that a mammogram every other year is as effective as every year, and in addition to that, a number of women that I know who have had breast cancer found it on their own. So what's your opinion in terms of breast cancer? How often should we be getting one?
Well, there's no doubt that mammography is not a perfect test, and that's why people will say, well, gee, I know someone who had cancer, mammogram didn't pick it up, I'm not getting a mammogram. There is no perfect medical test. All heart attacks don't show up on an electrocardiogram, but you wouldn't decline to have an EKG when you were having chest pain, and the same thing is true about mammography. I think there's very convincing evidence, particularly for younger women in the 40 to 50 age group, where their mammograms may be more difficult to look at, that you can pick up subtle changes comparing year by year by year. So I would say annual mammography remains the standard, except perhaps for women once they get over the age of 70, where their breasts are mostly fatty and easy to look at.
Now, you mentioned earlier advances in terms of genetics. A number of people have read recently about people, one woman in particular that I can think of, who wrote a book about her experience. Her mother had breast cancer, survived it, 2 years later died of ovarian cancer. She has a genetic predisposition for cancer according to a recent test, and opted for a complete mastectomy and is planning at age 40 a hysterectomy. I'm wondering what your feeling is about that kind of response.
Well, we have learned that there is a small, and I would emphasize it is a small group of women. It accounts for only 5 to 10% of women with breast cancer who do have a genetic predisposition that we can identify based on abnormalities of one of two genes called BRCA1 and 2. And one important thing to know is that you can inherit this from your father or your mother. So people only used to pay attention to the mother's side of the history. Was there breast cancer on the mother's side? Knowing your father's side is important too. And if you happen to have one of these genes, you have a risk of getting breast cancer during your lifetime that's somewhere from 40 to 80%, which is very enormously much higher than virtually anything else we know. And so for some women faced with that level of risk, they opt to remove their breasts as a preventive strategy because that's the most effective prevention we know. It is a radical strategy. Other alternatives, for example, taking out the ovaries will reduce that risk by half if you're premenopausal and you're done having your family. And it also helps to protect against the ovarian cancer that's associated with those genes as well. So most women who are concerned about breast cancer don't fall into that category. If you have a lot of relatives on one side of the family with breast cancer, particularly at a young age, or the combination of breast and ovarian cancer, seek out a genetic counseling service to talk about what your risk is.
Let's talk a little bit about chemotherapy, because I understand a number of women are undergoing chemotherapy unnecessarily, and that's not to say that chemotherapy isn't effective for some women with breast cancer.
Sure. Well, that's been one of the problems, is we know chemotherapy is effective, but we've lacked the tools to say to an individual woman, yes, it'll be effective for you, no, you don't need it. Part of what this new genetic era is doing is allowing us to do much more focused studies to say, if your tumor has this combination of genes or these kind of markers, are you going to benefit from chemotherapy, and what kind is best? The other issue is, how much risk are you willing to take to avoid chemotherapy? And that's a question you should ask your doctor. How much benefit am I likely to accrue from taking this treatment? For some women, if you say 1%, they want it.
I understand that there's now a computer tool that will help predict the risk of breast cancer returning. Can you tell us something about that?
There is a computerized model, and many physicians use this in counseling women about chemotherapy that takes certain things that we know predict breast cancer behavior, involvement of the lymph nodes, size of the cancer, what it looks like under the microscope, how old you are, puts that together based on actual information that's been gathered from patients, and says, if you take no treatment, your risk of dying over the next 10 years will be 17%, to pick a number. If you use this treatment, that can reduce that risk to 10%. So it still doesn't tell you, for you, it's 100% one way or the other, but it gives you a context.
Women living in North America have the highest rate of breast cancer in the world, and rates do vary across the globe. Why is it that women have a higher incidence of it in North America than other places? Do we know why?
We don't know for sure, but we have a number of good ideas. Part of it is that in North America, as in other industrialized nations, there's good nutrition that leads to getting your period early. Higher socioeconomic status is associated with delaying childbirth, another thing that's associated with increased breast cancer risk. This has led to a lot of interest in diet, but nobody has ever been able to clearly show within the context of an American diet that, for example, the amount of fat you eat is associated with your level of breast cancer risk. Pesticides, environmental exposures, again, people have looked fairly hard at those things, not been able to come up with any conclusive evidence.
There has been a decline in hormone therapy for women going through menopause. My guess is that is playing some role in the decreasing numbers of breast cancer cases.
That is definitely a factor. We know that combined hormone replacement therapy, estrogen and progesterone, increases breast cancer risk, and that does seem to account for a part, at least, of the drop in number of cases we're seeing.
How important is early detection, and what are the key factors to finding breast cancer early?
There's no doubt early detection is important. It's not a guarantee, but it's one of the things that you can actually do. So annual mammography over the age of 40 is important. Having your breasts examined as part of your routine health care at least once a year is important. And for most women, breast self-examination gives you the opportunity to pick up those lumps that may not be seen on mammogram.
You mentioned some of the myths just a moment ago, but I'm wondering if you were going to advise someone right now who got a diagnosis of breast cancer, what's the first thing they ought to do?
Well, the first thing they ought to do, again, is take a deep breath, sit back, and recognize that they have time. Breast cancer is not a death sentence. In fact, breast cancer is one of the most treatable cancers that we see. So there is lots of hope for care. I think many of the myths about breast cancer are before the diagnosis about who's going to get it. Nobody in my family has had it. I don't need to worry. That's not true. Most women who get breast cancer have no family history. Being a woman and getting older is the biggest risk factor that there is.
We hope we're all going to do that, right?
Exactly.
Now, each patient outcome is as unique as the person we're talking about, but what kinds of people, in your experience, have the best outcomes?
Well, I think people have the best outcomes who are, number one, engaged in their care, but who do standard therapy. The myth that we have a cure for breast cancer out there that doctors are keeping from the public so that they can have business is unbelievably silly to me. I mean, I'd be happy to retire because there was no more breast cancer. It's not happening right now. So I think engaging in dialogue with your doctor, doing your treatments, keeping your appointments, taking your pills, all those things really do contribute to your outcome.
All right, thanks so much for talking with us.
Thank you.
Our guest has been Dr. Monica Morrow. She is Chief of Breast Surgery Service with the Memorial Sloan Kettering Cancer Center in New York City. For all of us here at WPSU, I'm Patty Satalia. Thanks for joining us. Have a good night.
A copy of the program you've just seen can be purchased through Penn State Media Sales at mediasales.psu.edu or by calling 800-770-2111.